I like your outfit, Cabri. Very, very colorful, very cheerful. This is why Africa is a cheerful country, a continent.
Yeah, actually, this outfit, Cameroon is really a large country with many tribes, and there is a northwest and southwest area where they speak English, and the other 8 regions they speak French. And this attire is the attire of the northwest region of Cameroon, meaning that if you see someone with this attire in the world in general is coming from Cameroon, and mainly the northwest region. Yeah. And again, and many other tribes, they are having also their own attire, and sometimes we, from Cameroon, we take everything from everywhere, and we promote our culture that way. Anyway, my presentation was how I do manage, or how we do manage ventricular ectopy in the country. Okay. For those who don't know Cameroon, Cameroon is a nice country, triangular country in Central Africa, and they call Africa in miniature. Why? Because almost all climates of Africa are in Cameroon. In the north part of Cameroon, it's like the desert. In the middle part of Cameroon, it's like, a savanna, but in the south, there is forest, meaning that we have everything there. And the population of Cameroon, too, is very cosmopolitan. In the north, there are Arabs. In the middle, there are Arabs in Cameroon. In the middle, the population is like joined, and in the south, we are having Bantus.
You have 2 languages, English and French.
Definitely.
And you speak both?
Yes.
So, you spoke Spanish also?
No, Italian.
Italian?
And Russian.
Oh, multilingual.
Yeah.
So, some parts speak French in Cameroon and some parts speak English, right?
Definitely. The northwest and the southwest, they speak English, and the 10 other regions, they speak French.
Okay.
That's why, everyone coming from Cameroon, at least, when you have a medical doctor or when you are having high studies, you should speak the 2 languages. And you are all very welcome in Cameroon. Probably the next meeting of AFRA can be in Douala or Yaoundé.
Oh, yes, yes. I will record it.
You're very welcome. You're very welcome. How do I manage patient with ventricular ectopy in Cameroon? Or how we, cardiologists in Cameroon? This will be the outline of the presentation. And we will start with this first recorded description by Pierre Tislo around 600 before Christ. And he noted the irregularities that did not interfere with normal lifespan. And they were occasional, but the prognosis was not so good. An ectopic beat is a disturbance of the cardiac rhythm frequently related to the electrical conduction system of the heart, in which beats arise from fibers or group of fibers outside the region in the heart muscle, ordinarily responsible for impulse formation. The causes here for the 2 previous days, we have been talking about all these issues, acute and chronic ischemic heart disease, valvular heart disease, cardiomyopathy, mitral prolapse, stimulants as caffeine, cocaine, nicotine, alcohol, so many other problems like metabolic abnormalities, and some drugs also. The pathophysiology, yesterday our colleague also mentioned this, the pathophysiology of arrhythmia in general, that includes automaticity, reentry circuit, triggered activity. We know that the clinical evaluation of ventricular ectopic beat is associated with several characteristic findings on history, physical examination, and ECG. Sometimes they can produce symptoms, and the vast majority of patients, the underlying causes, because of many underlying causes, the ectopic beats can be corrected without the use of medication, but a thorough workup is very important. An ECG absolutely should be part of the standard evaluation for any patient with suspected ventricular ectopic beats. 24 to 48 hours of ambulatory ECG monitoring significantly increases the likelihood of making the diagnosis, giving a sporadic nature of ventricular ectopic beats in most patients. And I know that everyone in this room at least knows how it presents itself on the ECG tracing. This is what we have, you know, the first bit on the first image that is having, you know, a particular type of presentation, and the third bit also. This is what is called a ventricular ectopic beat. And also, you know, there's a full compensatory pulse. Classification. Many of us, you know, this classification of Lundgrad system. There are many other types, the pattern-based classification, and also morphology-based classification. Unifocal, multifocal, we know everything. And again, they are benign and malignant ventricular ectopic beats. And we see when they are benign, there's no familial history, there's no history. The ECG monitoring, what happened? The connection here is a bit having a problem. It's just fluctuating, going and coming. If the technician can come here. And anyway, if to continue the presentation, we are almost 115 cardiologists in Cameroon with a population of 30 million inhabitants. And before coming, I asked them which practice do they have as far as ectopic beats are concerned. Since in Cameroon, for the moment, we are having a center, the only private center for ablations, EP center, where they do ablations of simple cases, pre-excitation and atrial flutter. Definitely, the devices, we implant all devices, but as far as ablation are concerned, we are limited to simple cases. And they told me, the majority told me that the only way they manage those ectopic beats is using beta blockers. Some can use amiodarone for some cases. And since we are not yet having ablations of ventricular ectopic beats, we don't do them in Cameroon. When we are having those cases, we send abroad, we send somewhere where they have the facility and it can be done. Until now, there was one patient referred by a cardiologist from a different city, from Yaoundé. Until now, we are waiting. In the follow-up, the patient disappeared. We are just recalled, and it looks like probably has traveled. We don't know when he comes back. Probably he will do again the ECG and see, or he will tell us what has been going on. Thank you. Yes, the clinical evaluation. Electrolyte imbalances, in particular low serum potassium, low magnesium level, and again, you should look for underlying structural heart abnormalities that can predispose to ventricular ectopic beats. And we should assess the degree of left ventricular dysfunction by non-invasive technique, such as the echocardiography or radionuclide imaging. Also, an EP study can be done in those with a structural normal heart with some symptomatic ventricular ectopic beat, or for whom pharmacological treatment or catheter ablation is indicated, and those with structural heart disease for whom certification of sudden death is requested. The approach of the management of ventricular ectopic beats depends on the frequency, the attributable symptoms, the presence of absence of underlying structural heart disease, and the estimated risk of sudden cardiac death. For asymptomatic patients, recommended treatment usually involves patient education and reassurance and avoidance of aggravating factors. That's what usually we do in Cameroon. Those patients sometimes who are very nervous, who are in stressful conditions, who are drinking much beer, or who are smoking. This is what we do. And in symptomatic patients, the treatment of choice, a beta blocker. And if the beta blockers are not really successful, we can use an anti-arrhythmic drug. Those anti-arrhythmic drugs are not really available in all parts of Cameroon. That's why beta blockers really are the first line, and it can be found everywhere. Also, ablation therapy is recommended for patients with frequent symptomatic and monomorphic ventricular ectopic beats that are refractory to medical therapy, or patients who choose to avoid long-term medical therapy, or patients with ventricular arrhythmia storm that is consistently provoked by ventricular ectopic beats or a similar morphology. As I said, in Cameroon, mostly, we are having therapeutical management of the problem, and those who need ablation they are referred in other centers. Thank you.
Thank you so much, Dr. Cabral. Any questions for...
Yes, for Cabral, I want to tell you our experience in Egypt with limited resources. Outflow tract PVCs, we do them conventional, especially if the patient cannot afford the price of the 3G. For other non-outflow tract PVCs, 3D mapping and contact force is of utmost importance. But we did ablations of PVCs from these sites, even in children with conventional ablation. So if you train yourself and get the knowledge of localization by ECG first, then it's very easy to go and to map and to do this ablation.
Thank you. Probably in the near future, with the partnership of Africa and your collaboration will be done. I believe so.
Yes,
Thank
yes.
you.
Other questions? No, thank you. Is Ashley Chin here?
We're calling him. You start the
great.
next...
So the next, so we're going to move now to abstract, just a few abstracts before we break. So Ashley Atuti, are you in the room?
No, the next one, second one.
Is Hazel Kariuki in the room?
Karaoke? Okay, go for Willie. Willie?
I think she is here. Yeah, Hazel's
Karaoke?
Hazel's here. So,
Yes, please.
the next talk will be by Hazel Kariuki. This is a 10-year review of peri-procedural complications associated with advanced cardiac implantable electronic devices in East Africa.